we'll be hearing from Mr. Emmanuel Nyama, as well as Mohammed Soare, who are both community health officers, actually, in a very rural district of Sierra Leone, and work with the organization Partners in Health in establishing a hepatitis B program. So the floor is over to them. Thank you very much.
Hello, good morning, good afternoon, across the globe. I am Mohammed Soare, a community health officer working with Partners in Health in community KGH, particularly in LCD clinic. I am here with colleagues, but they will introduce themselves as we go along the program.
Hi everyone, I am Emmanuel Nyama, a community health officer working for Partners in Health in Kono District, eastern part of the country. Partners in Health is a non-governmental organization that is working for strengthening the health system in partnership with the government and helping the vulnerable people in the society. So,
hello, this is Marta Patiño. I am the internal medicine doctor working for Partners in Health and coordinating all the hepatitis B program.
Yeah, so we can dive into the program or the presentation proper. So before we go further, I want to just give you the kind of status of hepatitis B in our country in general. So Sierra Leone has a population of 7.6 million people with a life expectancy of 53.9, and then the fertility rate in children is like 4.3%. So we want to give you exactly the kind of a burden or the kind of prevalence of hepatitis B in our country. As various studies have suggested or have shown that the prevalence of hepatitis B is high. In general, it is above 10% of our population. So we want to talk about the strategies we are implementing in order for us to tackle the hepatitis B. So the government and together with development partners or whatsoever, they've tried to put in vaccination as part of the protocol, which was introduced in 2007 to ensuring that people that were born or that are now born can be vaccinated. But you can imagine this gap that has been created for far too long before the introduction of this vaccine, the kind of gaps, especially for children, women now in the reproductive age that have not been vaccinated. So imagine the kind of gaps that has been created. So we also want to talk about slide 5. So, as you can see, we are dealing with a national guideline or a protocol that is accepted all over the world. We are using a kind of first-hand diagnosis tool in our country because we all know that the prevalence of the hepatitis B in our country is too high. So we are using just a single test for our diagnosis purpose. So you also may want to see the reality or the challenges we are faced with in terms of diagnosing this patient. Yeah, so we are expecting people to pass through this kind of entry point into the care, but it's challenging because what we are expecting to be done is not done due to the several challenges with transportation, linkage to the service, and all those things. So you see, our country is a very poor country with a population that is 60% of the country population is poor, and they are living below the poverty margin that is $1 a day. So they cannot afford to provide themselves this kind of a service. Yeah, but the hepatitis B care is also part of this, that the government is not financing. We have a government that is just financing few health care services like malaria, like TB, like HIV and the NAME services and all. But you see, the majority of the people or the population are left out. So even though if we have the technical know-how, we have the kind of support we need, but we cannot afford, people cannot afford to access the care because of the poverty level. So as we go along the line, we want to for our colleagues to come in and do the presentation about the status of hepatitis B or how our clinic operates in Kono district.
So this is the reason, because of the poverty and the poor economic status of the country, that our partners in health and partnership with the government decided to open the first free hepatitis B clinic in the country since April 2019. So partners in health operate in Kono district, as you can see from the slide. Now, Kono district is a district in the part of the eastern part of the country, and we have a catchment population of around 500,000 people, and with only one secondary hospital, secondary facility, where the hepatitis B clinic is located, and 97 primary facilities, 15 chiefdom, 11 community health centers. It may interest you to know that 75% of all these population live in the rural areas. So there is a big challenge for them to access a clinic, because those rural areas have poor road network, and most of them use a motorcycle as a means of transportation to access care. So there is a big problem for them to access the care because of the poor economic status. So some people take over more than 2 hours to access care, and this impedes their accessibility to the clinic in the hospital. So the next slide you see is telling you about the hepatitis B reporting and linkage system, the care cascade we give to our patient. You see, and the first thing there is that whenever a diagnosis is made or a patient is referred, they are given an appointment in the clinic, given a date, and in the time of giving the date, we brought an innovation, which is a diagnostic or evaluation package, wherein the individual is given laboratory investigations and ultrasound image request form to do all the evaluations before coming for the first visit. In the first visit, the individual undergoes evaluation, counseling, and then start immediately on treatment if the individual meets the criteria for treatment. This initiative alone has increased the adherence of care for a patient to the clinic. The pictures I'm sharing with you tells you about how the clinic runs. The first picture you see on the far left there, up left, is the entrance into the clinic. Button to that is that a consultation room or an examination room with Dr. Chembe, one of the doctors that has been working with us here but is no longer here. And next to him is a nurse Kumba, who is one of the nurses in the clinic. And then at my far bottom left is the register where the patient is registered and linked in the clinic. You see a picture of the laboratory result of the viral load, which I'm going to talk about in the next slide. And then in the next picture, you see a pharmacy technician providing tenofovir to a patient with indication of treatment. So it means, before I forget, is that the clinic is part of the non-communicable disease clinic in the hospital, and the team consists of 1 medical doctor and 2 community health officers, 4 nurses, 1 M&E officer, and 1 clerk. So the slide you see here is telling you about the testing cascade we use in the clinic. So on the far left there is a rapid test we use to detect hepatitis B surface antigen, and also why we are using is that the test is so cheap and also has high sensitivity and specificity value. And as well as the testing cascade, we have introduced the since 2019, we introduced the hepatitis B viral load in the algorithm of treatment of hepatitis B based on WHO guidelines. So you see that the viral load has helped in the accuracy of treatment, particularly if the individual, if we are comparing it with abnormal ALT level, when we know that the ALT level can be abnormal in many conditions. And as well, also it improve our judgment, particularly at initial visit. If it is elevated with elevated ALT level, we start the patient on treatment immediately despite other findings. Also, in the last bottom there, the picture you see is the hepatitis B serologic kit or panel, which we use for our patients, most of them who are adolescent or below 30 years of age. We use it to see whether they are in the immunotolerance phase, to see whether the hepatitis B early antigen is positive or not. So in the clinic, we have main areas or sources of our patients where patients are referred from other places to access the clinic. In 2020 April is that at the outpatient departments, took the chunk of the patients that were referred to us. 60.8% of patients that were referred to us came from the OPD, and some are coming from discharges in the ward, external clinic, ANC, HIV and TB clinic, and also in the blood bank. But I want to let you know that there is no proper screening program, particularly for key populations that are affected with hepatitis B, and also there is not that good linkage system into the clinic. And also, most of our patients don't know why they are coming to the clinic, and a small number of them will tell you that I have a liver condition, but it may interest you to know that no one will tell you that I have hepatitis B infection. So the next slide you see here is talking about the evaluation and the treatment cascades in terms of hepatitis B management in the clinic. So we see the eligibility criteria for our patient to start treatment is based on one, the ultrasound finding and the APRE score. If on the ultrasound finding there is evidence of cirrhosis and also the APRE score is greater than 2, if the cirrhosis either decompensated or not, we start the individual on treatment. Also, if the patient is co-infected with HIV or hepatitis C, is a criteria for treatment. And also if the patient has a viral load greater than 20,000 with a persistent abnormal ALT level, we put the individual on treatment. For pregnant mothers, if they have viral load greater than 200,000 and also they have hepatitis B early antigen that is positive, we put them on treatment. For the follow-up, we check in terms of adherence to treatment and also check the urine creatinine level every 6 months for patient not on treatment, and then patient on treatment, we check the viral load every 12 months. So the slide you see is a follow-up for patient not on treatment. What we do is that we review the patient based on ALT level and viral load. So this slide tells you about that. And also in terms of vaccination is that there is no dose vaccine or national guidelines for vaccination for babies born to hepatitis B positive mothers. There is no hepatitis B screening program in the antenatal care unit nationally. So in the clinic, what we are doing is that positive mothers is that we have started vaccinating the babies born to positive mothers in the last 8 months. So to give the first dose of vaccine to babies born positive mothers in the last 8 months, we are using the vaccines that we are left from the campaign we did, hepatitis B campaign we did 1 year ago to vaccinate the babies born to positive mothers. So the challenges we have, as I mentioned earlier, is that there is no national program for vaccination of babies born to positive mothers, and also There's not that proper linkage system and follow-up from the clinic to see who those babies that are born are either vaccinated or not. Our future vision is that we would like to do a universal vaccination to all babies. Okay, give a first dose of vaccination to all babies, despite the status, the hepatitis status of their mothers, and then also continue with the program of prevention of mother-to-child transmission. So the next slide you see is a B evaluation and treatment. In terms of, these are specific groups of patients we are deciding to be putting on treatment in the future. So those with abnormal ALT level greater than 80 and viral load between 2,000 and 20,000, and then their APRI score is greater than 5. Because we found out that some of these patients with APRI score between 2 and 1.5 already have evidence of cirrhosis, but we are not putting on treatment. So we want to put this patient on treatment in the near future. And also in terms of the children, we want to be using criteria like if you have ALT level 1.3 times the upper limit of normal, at least 6 months with high viral load, and also if you have a high viral load during childhood greater than 1 million, we want to start putting this patient on treatment. The slide you see is talking about the data we recorded in April 2020 about the patient we put on treatment. We have 351 patients. Out of this, 12.8% were placed on treatment, which constitute 45 patients. 7.1% of these diagnosis for this indication of treatment was based on ultrasound finding. 53.3% was APRI score, which was 2 and above. And then also those who have both APRI score and ultrasound findings were 24.4%. Those who were successfully initiated on treatment were 8.2. Out of this, there was no one hospitalized. And then those who are retained on treatment, 94.6%, and they are still on treatment. The next we want to talk about is the hepatitis B care cascade challenges. Is that in terms of screening, no systematic screening for key populations, no national program for prevention of mother-to-child in terms of transmission of hepatitis B, and no systematic tracking system to ensure all the positive patients that are maybe referred from other areas are coming to the clinic or not. And also in terms of the linkage, we don't have the systematic linkage system from the areas of screening, the blood bank, the ANC, the outpatient with the clinic, and no referral system, particularly from other districts and facilities in our district to send patients to our clinic. There is not that a proper referral system. And there is no tracking system or a linkage system for patients to relink them. Those who are on follow-up, those who are out of follow-up, there is no that proper system. And we also lack the systematic evaluation of patients that meet the vulnerability criteria. So also you see that the hepatitis B cascade of care challenge. The challenge is here is that in terms of treatments, we still don't have accuracy of indication of treatment based on the gadget we are using, the ultrasound and the APRI score. We don't know if it is accurate or not because we don't have a fibroscan which could help us to say that yeah, this is cirrhosis or not. And then also we have patients that are on treatment that comes with GI bleeding. We don't have endoscopy to know whether the source of their GI bleeding is from the cirrhosis or from other causes. And also there is delay in supply of viral. Recently, we just got a new supply. We are out of supply for over the last 4 months. This also creates a big problem in terms of deciding whether the patient should start medication or not. And then we don't have intercover for children to start treatment, but which we are sure of having in the next few months to come to start our children on treatment. And then also, it may interest you to know that high number of these patients are uneducated, so we find it difficult to explain the cause of the disease, the consequence of not following up, not adhering to treatment, and not coming for follow-up. And then we will, in terms of decentralization, to see that what we are doing is disseminated to other districts is a big challenge. In terms of immunization, as I've said earlier, there is no national policy for giving first dose of vaccination to babies born to positive mothers, and no national policy for close contact of positive patients. And I will tell you this, that there is no sensitization going on in the country about the hepatitis B clinic, except where we work in Connaught District. And lastly, I will like to end with these operational research opportunities. In terms of development of prevention of mother to child transmission program in hepatitis B, and then accuracy of April score or the use of ultrasound finding in terms of identifying cirrhosis without the use of a fibroscan. If you use a fibroscan and use these two, which one is more accurate? And then identification of prevalence of hepatitis B in key population, especially pregnant mothers and then children below age of 5, and then prevalence of hepatitis B in primary contact of positive population, and then also the implementation of follow-up program with the participation of community-based program to prevent loss of follow-up and then identify complications. Thank you. Thank you very much. If you have questions, you can let us know where you don't understand. We can help you clarify.
Thank you so much, Soare and Nyama, for the excellent presentation from Sierra Leone. For the sake of time, I'm going to invite our final speaker, who's Dr. Kasamir Manzango. Dr. Kasamir, you can come off mute and on video. Dr. Manzango is a medical advisor at the WHO Africa Regional Office, and he's also the acting regional hepatitis advisor for the regional office in Afro region. So Dr. Kasamir,